Hello, CHD. I'm Heather Ray, and this is Vaccine of the Week. Every week, we break down a vaccine packaging insert from the CDC immunization schedule. We examine the disease it's intended to prevent and discuss the vaccine itself. We also cover some topics that you, as a parent, might want to be aware of. Today, we are talking about the DTap vaccine, Infanrix. The CDC recommends all children receive 5 doses of the DTap vaccine. The first dose is given when an infant is 2 months old. The second dose is given at 4 months, the third dose is 6 months, the fourth dose between 12 and 15 months, and the fifth dose is given between 4 and 6 years old. The Infanrix vaccine is intended to protect against 3 separate bacterial infections: diphtheria, tetanus, also known as lockjaw, and pertussis, commonly known as whooping cough. Diphtheria is a very rare bacterial infection in the United States. The last confirmed case of respiratory diphtheria was in 1997, and the last death was in 1987. The Corynebacterium diphtheriae causes respiratory diphtheria. What makes the diphtheria bacterium different from a typical sore throat is that it kills the cells in your throat, causing a thick gray coating over the throat and tonsils, and it can make it hard to breathe. It's contagious, and it is typically transmitted through respiratory droplets of an infected individual. Individuals who are infected with respiratory diphtheria can experience symptoms 2 to 4 days after exposure. These symptoms may include a thick gray pseudomembrane over the throat and tonsils, sore throat and hoarseness, swollen glands and swollen lymph nodes, mild fever, and tiredness or weakness. While respiratory diphtheria can be serious, it is often mild or asymptomatic. If respiratory diphtheria is left untreated, the toxin can get into the bloodstream and cause complications that can be life-threatening or fatal. It's important to know that respiratory diphtheria can be treated with antibiotics like penicillin or erythromycin, and an antitoxin that will counteract the diphtheria toxin in the body. There have been a few isolated cases of non-respiratory diphtheria in the U.S. since 1997. All of those cases were mild or asymptomatic and did not lead to serious injury or death. Several of the individuals who contracted non-respiratory diphtheria were returning from diphtheria endemic countries and were up to date on their diphtheria toxoid-containing vaccines, but they still contracted the illness. Non-respiratory diphtheria, also known as cutaneous diphtheria, is caused by the same bacteria as respiratory diphtheria. However, instead of infecting the respiratory system, it causes lesions on the skin. Cutaneous diphtheria is less severe than respiratory diphtheria. While cutaneous diphtheria is also contagious, people with this infection typically don't become infected with concurrent pharyngeal diphtheria. Diphtheria typically occurs in places with a tropical environment, like Asia, Africa, the South Pacific, the Middle East, and the Caribbean. And people who live in endemic countries and unsanitary conditions are at a higher risk of contracting the bacteria. Toxic strains of the bacteria are rare, and systemic complications occur in only 1 to 2% of cases. Of the toxigenic diphtheria cases, only about 5 to 10% are fatal. Both respiratory and cutaneous diphtheria are treatable with antibiotics like penicillin and erythromycin, and if needed, an antitoxin, which will counteract the diphtheria toxin in the body. Antibiotics may be given to individuals who have been in contact with someone infected with diphtheria to prevent them from contracting the illness. While many praise the widespread use of the diphtheria toxoid vaccine for the decline of diphtheria mortality in the U.S., it's important to note that while the vaccine was developed and approved in the U.S. in the early 1920s, it wasn't widely used until the 1940s. If you look at this graph, you can see the deaths from diphtheria were on a steep decline decades before the vaccines were developed. The sharp decline is more appropriately attributed to better hygiene, improved sanitation practices, improved living conditions, and better nutrition. Tetanus, also known as lockjaw, is a bacterial infection caused by the bacterium Clostridium tetani. This is a type of anaerobic bacterium, which means it thrives on environments with low oxygen levels. This particular bacterium is commonly found in the soil and the gastrointestinal tracts and feces of animals, particularly livestock. Spores of C. tetani, the dormant form of the organism, are found in soil contaminated with animal and human feces. The bacteria will lie dormant in animal feces and feces-ridden soil until it finds a host that has an optimal condition for growth. Once the bacterium finds an optimal environment, it germinates, and that organism can then produce a potent toxin, tetanospasmin. The bacteria can enter the body through an open wound or a break in the skin that has been exposed to contaminated soil or manure. From the time of the infection to the time that symptoms set in is approximately 10 days, although symptoms can appear in as little as 3 days or as late as 3 weeks. There are 4 different forms of tetanus. Generalized tetanus is the most common. Symptoms typically start in the neck and jaw, progressively worsening and spread down to the body. Painful muscle spasms and stiff muscles in your jaw causing the lockjaw effect. Painful spasms and rigidity in your neck muscles. Difficulty swallowing. Rigid abdominal muscles. And as tetanus progresses, individuals may experience repeated painful generalized muscle spasms. Spasms in the neck and abdomen may also make it difficult to breathe. Localized tetanus is very uncommon. This is when an individual experiences muscle spasms near the site of the wound. Localized tetanus can progress into generalized tetanus. Cephalic tetanus is a rare condition that typically occurs in conjunction with a head wound. The muscles around the face and jaw become weak and spasm. Cephalic tetanus can also progress into generalized tetanus. Neonatal tetanus is also very rare in the United States. This happens when the umbilical cord of a newborn becomes infected due to unsanitary delivery or contamination. When this happens, newborns lose their ability to suck during the first month of life, and they have muscle spasms. Tetanus is not contagious, and it's not a communicable disease. Infection with tetanus is rare in the U.S., and cases have declined by over 99% since the 1900s. Over the last 25 years, the U.S. has only averaged about 2 deaths per year from tetanus infection. Additionally, between 2013 and 2022, there were fewer than 10 cases of tetanus in children under the age of 5, and only about 50 cases in children and adolescents younger than 20 years old. There were no deaths from tetanus reported in individuals under 60 years old. Of the 267 cases and 13 tetanus-related deaths in the U.S. between 2013 and 2022, vaccination status was only known in 25% or 67 of those individuals. Of those 67 individuals for whom vaccination status was known, about 24% received 3 or more doses of the tetanus toxoid vaccine. I believe this is something we should really consider when evaluating the efficacy of the DTap vaccine Infanrix. If a person becomes infected, the infection will need to run its course, which may take 2 weeks, and recovery may take up to a month. Medical treatment and supportive care may be necessary to ensure wounds are cleaned properly. Antibiotics and antitoxins are administered intravenously. Medication is given to relieve spasms, and breathing is supported if needed. Ensuring that wounds are cleaned and dressed appropriately can prevent bacterial infections. Using tetanus immune globulin for prophylaxis and wound management and the treatment of tetanus has prevented cases and reduced the severity of tetanus cases. Hygienic childbirth, the use of antiseptics, and improved wound care have also assisted in the decline in tetanus mortality in the U.S. since the 1900s. Much like the diphtheria vaccine, the tetanus vaccine is widely praised for its role in the decline of tetanus mortality in the U.S. However, if you look at this graph, you can see that tetanus mortality was also in rapid decline decades before the widespread use of the tetanus vaccine in the late 1940s. Pertussis, also known as whooping cough, is a common bacterial infection that is caused by the bacterium Bordetella pertussis. This is not to be confused with Bordetella bronchoseptica, which causes kennel cough in dogs. Bordetella pertussis only occurs in humans and mostly in young children. Whooping cough is common in the U.S. and most cases are mild. In fact, about 82% of the whooping cough cases in the US are benign and aren't even reported to the health department. It may take 5 to 10 days for the symptoms of pertussis to set in after a person has been infected. Symptoms may be similar to those of a cold or flu, including a runny or stuffy nose, red, watery eyes, fever, and cough, and the cough may worsen progressively over a week or two. Babies with whooping cough may not cough at all, but may struggle to breathe as the infection progresses. Younger children may make the traditional high-pitched whoop when they breathe in after coughing, and adults and older children may not make the whooping sound, but still experience relentless coughing and hacking. Most of the time, pertussis infections only require supportive care, like rest, plenty of fluids, and keeping the air you breathe clean from dust, cigarette smoke, and fumes. If needed, whooping cough can be treated with antibiotics, which kill the bacteria that cause the infection. A holistic, integrative, or functional medical doctor can help you find relief from the cough itself. Once again, the pertussis mass vaccination campaign is often credited with the decline in pertussis mortality rates. But in reality, mortality rates from pertussis decreased 92% between 1900 and 1945. Infants under a year old are most at risk of complications from whooping cough. Still, research shows that without vaccination, infants under 1 year old only have a 1 in 47,000 chance of developing a fatal case of pertussis. That's 0.002%. Infanrix was initially approved in the United States in 1997. It's one of 2 vaccines approved in the US for infants and intended to protect against diphtheria, tetanus, and pertussis infections. Infanrix is manufactured by GlaxoSmithKline, and it's approved for use in infants 6 weeks old to children under 7 years old. Infanrix is not a live virus vaccine. It's a combination of diphtheria and tetanus toxoid vaccines and an acellular pertussis vaccine. This means the vaccine contains killed or inactivated components of the diphtheria and tetanus toxins, as well as fragments of the pertussis bacteria, to stimulate an immune response in the body. The pertussis portion of Infanrix does not contain whole cell pertussis bacteria. The US stopped using whole cell pertussis vaccines in the late 1990s due to concerns over safety and efficacy. Adverse reactions from whole cell pertussis vaccines include encephalopathy, neurological disorders, febrile seizures, and hypotonic or hyporesponsive episodes, which is when a child experiences a loss of muscle tone or appears floppy and has a loss of responsiveness to stimuli. SIDS, or sudden infant death syndrome, is also an adverse reaction from whole cell pertussis vaccines. Now let's look at some issues that are particularly concerning about toxoid and acellular components in the Infanrix vaccine. The diphtheria and tetanus toxoid vaccines use a toxin produced by the bacteria that cause the infection. The vaccine is designed to induce immunity to the parts of the bacteria that cause infection, rather than the bacteria itself. In other words, the immune response targets the toxin made by the diphtheria and tetanus bacteria instead of targeting the entire bacteria. One of the problems with toxoid and acellular vaccines is that they often require a larger dose and use adjuvants to acquire a proper immune response. In the case of the diphtheria and tetanus toxoid vaccines and the acellular pertussis vaccine, each contains aluminum hydroxide, which is a known neurotoxin. We'll discuss aluminum adjuvants and their effects in just a few minutes. Because toxoid vaccines require a larger dose, that means they also come with more adverse reactions, which can be really scary. One of the most important things that parents and caregivers want to know is if the vaccine is effective. Does it prevent infection and transmission of the disease it was intended to protect against? While the vaccine packaging insert states that Infanrix is effective, many peer-reviewed scientific studies show that the efficacy of diphtheria and tetanus toxoids and acellular pertussis vaccines wane over time. For instance, the diphtheria toxoid vaccine may prevent symptoms of the infection, but it doesn't prevent carriage or the spread of diphtheria. Even fully vaccinated individuals don't achieve 100% immunity to the infection, and some studies suggest efficacy is as low as 54%. With tetanus, the clinical efficacy of tetanus toxoid has never been studied in vaccine trials. One study shows that efficacy can vary depending on sex and race, with efficacy being almost 20% higher among men than women. Mexican Americans didn't even achieve 60% immunity, and Blacks only achieved about 68% immunity. Non-Hispanic whites only a little over 72%. Age also plays a part in the efficacy of the tetanus booster. While the efficacy rates of 6-year-olds in America was over 95%, probably because the majority had 5 doses of the DTap vaccine in less than 6 years, by the time a child was 10 to 16 years old, 20% of them didn't even have protective antibodies against tetanus infection. Because tetanus is not contagious, the vaccine does not affect the transmission of the illness. When we look at the pertussis component of the Infanrix vaccine, efficacy is low, and immunity from acellular pertussis vaccines wane quite quickly. Individuals who are immunized against pertussis can still contract whooping cough and transmit it to their peers. Some studies even suggest that repeated booster doses of the acellular pertussis vaccine in children result in a progressively shorter duration of protection against the illness itself, and the risk of pertussis increases with each year, even after children are fully vaccinated with the DTap vaccine. Furthermore, because efficacy wanes so quickly with the toxoid and acellular vaccines, booster doses are needed to try and boost immunity. As we begin discussing the adjuvants and other ingredients that comprise the Infanrix vaccine, along with the adverse reactions associated with it, I want you to keep this in mind. More boosters mean more toxic adjuvants and controversial ingredients being injected into your child. And with each additional shot, the risk of your child experiencing a vaccine injury goes up. We often hear in the media and from our doctors that vaccines are safe and effective. We've just discussed the efficacy of the components in the Infanrix vaccine. Now let's dive into the safety aspect. As parents, we always want to know if the vaccine that we are giving to our children is safe and if the benefits of the vaccine outweigh the risks of the illness it is intended to prevent. Infanrix is contraindicated for children who have experienced a severe allergic reaction, such as anaphylaxis, after a previous dose of any diphtheria toxoid, tetanus toxoid, or pertussis-containing vaccine, or if they've had a reaction to any component in Infanrix. It's also contraindicated for children who have experienced encephalopathy within 7 days of administration of a previous pertussis-containing vaccine, and for children who have had progressive neurological disorders. If we scroll down to section 5 in the packaging insert, we can see that there are warnings for syncope and apnea in infants who were born prematurely. The insert also cautions against administering Infanrix to children who have experienced previous Guillain-Barré syndrome with tetanus toxoid-containing vaccines, or who have had previous adverse reactions after receiving a pertussis vaccine. It goes on to warn that epinephrine should be available to control possible anaphylactic reactions in children who may have reactions to the vaccine, and appropriate antipyretics or fever-reducing or controlling medication can be administered at the time of vaccination for children who have a higher risk of seizures. There's also a warning for children who have experienced a temperature of 105 degrees Fahrenheit, collapse or shock-like state, or persistent inconsolable crying lasting 3 hours, or if a seizure occurred within 3 days after receiving a previous pertussis vaccination. Now, please note that these adverse events are not uncommon occurrences in children who receive DTap vaccines. In fact, seizures may occur in about 1 in 683 children vaccinated with DTap. When we examine the clinical trial information in section 6.1, based on the packaging insert, the U.S. clinical trials only specify 4 consecutive days of monitoring for immediate adverse reactions, and no information is provided regarding long-term safety monitoring periods for the U.S. studies. The non-U.S. safety studies had longer monitoring periods, yet even those did not exceed 30 days. The critical takeaway information that we need to know about the Infanrix vaccine is In the clinical trials, Infanrix was not tested against a saline placebo control. Instead, the manufacturer focused on demonstrating non-inferiority to existing vaccines rather than the absolute safety of the vaccine itself. U.S. studies primarily focused on the short-term safety of the vaccine for 4 days or less and did not report serious adverse events. Remember, there are no long-term prospective safety studies that evaluate the neurological and developmental outcomes of infants and children vaccinated with Infanrix. The CDC and vaccine manufacturers have failed to conduct proper studies, so we genuinely don't know the long-term effects or health outcomes for children vaccinated with this or any other vaccine. If we look at the adverse events in the clinical trials that are noted in the packaging insert, we can see that pain, redness, swelling, loss of appetite, and fever are very common after receiving Infanrix. However, when we examine the adverse events in the post-marketing experience and the scientific literature, a much grimmer picture emerges. Looking at the post-marketing experience in section 6.2, we can see that numerous adverse events were reported after Infanrix was released to the market. Remember, the post-marketing experience is the result of the experiment that vaccine manufacturers conduct on you, because 4 days or even 30 days is not nearly enough time to truly understand any short or long-term health outcomes related to the Infanrix vaccine. Here are a few of the adverse reactions that occurred after Infanrix was approved and released to the market. Remember, as I go through this list, these adverse events are happening in infants from 6 weeks to 6 years old. Sudden infant death syndrome, anaphylaxis, which is a severe, life-threatening allergic reaction that happens when your immune system essentially tries to fight off the threat of the vaccine and multiple systems in your body shut down at once. You can go into shock, your airways can close, your heart can stop, and it can cause death within just a few minutes. Apnea, which is a cessation of breathing. Cyanosis, which is a blue or grayish coloring of the skin due to the lack of oxygen in the blood. Thrombocytopenia. Now, this is a bleeding disorder where your body has a low platelet count, and it can lead to an increased risk of bleeding. Pneumonia, bronchitis, and respiratory tract infections. Encephalopathy. This is when the brain is damaged or normal brain function is disrupted, and it causes cognitive issues like confusion, memory loss, personality changes, and can even cause coma. Hypotonia. This is characterized by a loss of muscle tone. This condition is often seen in individuals who have cerebral palsy or muscular dystrophy. Syncope, which is fainting. Lymphadenopathy, swelling of the lymph nodes, and angioedema, and there are several more. These are extremely serious conditions that can be permanent or cause permanent damage. Several of these conditions can be life-altering or fatal. Since 1990, there have been 915 deaths recorded in VAERS that were caused by the DTap vaccine alone. This does not include any of the single diphtheria or tetanus toxoid vaccines or the pertussis vaccine alone. It also doesn't include any combination of diphtheria and tetanus toxoid vaccines or the pertussis vaccine with any other vaccines, such as Hib, polio, Hep B, or other combinations that are commonly used worldwide. Please keep in mind that VAERS is a passive surveillance system and it only captures adverse events reported to the system. If you read the Lazarus report, you will see that VAERS may only be capturing 1 to 10% of all vaccine adverse events. The peer-reviewed scientific literature also shows that the DTap vaccine can cause hemiseizure hemiplegia syndrome, which is a rare condition where a very long seizure damages the brain, paralyzes one side of the body, and causes lifelong epilepsy. Thrombocytopenic purpura, which is a bleeding disorder where a person has a low platelet count. Hypotonic or hyporesponsive episodes. This is when a child experiences a loss of muscle tone, making them limp. They may become unresponsive or have reduced responsiveness to stimuli, and their skin may become pale or even have a bluish tinge to it. Giannotti-Crosti syndrome. This is a rash of small, reddish or skin-colored bumps, primarily affecting the arms, legs, buttocks, and face. Anaphylaxis and death. In Section 13.1, the packaging insert states that Infanrix has not been evaluated for carcinogenic or mutagenic potential or impairment of fertility. So we don't know if the vaccine can cause cancer, if it can cause genetic mutations, or if it impacts fertility in our children. When looking at the dosing information in the Infanrix vaccine insert, we can see that every infant and child is recommended to receive 5.5 milliliter doses of Infanrix between the ages of 2 months and 6 years old. Again, the CDC recommends that children receive 1 dose of the DTap vaccine at 2 months, 4 months, 6 months, between 15 and 20 months, and again between 4 and 6 years old. Notice that the packaging insert does not include a chart showing different doses based on the weight of an infant or child. That's because even though most medications that you give infants and children are dose dependent on weight, even the over-the-counter ones, vaccines are not. So a 2-month-old infant weighing 12 pounds is given the same dose of Infanrix as a 6-year-old who weighs 50 pounds and is entering the 1st grade. Let's go to Section 11 and discuss some of the ingredients in the Infanrix vaccine. One of the things that a lot of parents would like to know about each vaccine is if it's made with aborted fetal cell lines. Infanrix is not made with aborted fetal cell lines. However, here are some other ingredients in the vaccine that are quite concerning. Each 0.5 milliliter dose contains 25 LFs of diphtheria toxoid, 10 LF of tetanus toxoid, and 25 micrograms of inactivated pertussis toxin. LF is an abbreviation for the limit of flocculation. The limit of flocculation is a method for measuring the potency of diphtheria and tetanus toxoids. It also contains 25 micrograms of filamentous hemagglutinin, or FHA, and 8 micrograms of protactin. FHA and protactin are proteins that naturally sit on the surface of the Bordetella pertussis bacteria. They stick to and infect the cells in your respiratory tract. The intended purpose of adding a piece of these proteins to the vaccine is that the immune system of a vaccinated child will recognize the bacteria if they become infected with whooping cough. The immune system would then attack the bacteria before they get sick. The diphtheria toxin is produced by cultivating the Corynebacterium diphtheriae in Fenton medium containing a bovine extract. This medium is often made with fetal bovine serum. Fetal bovine serum is a component of blood collected from the fetuses of pregnant cows at the slaughterhouse, and it's used to grow cells for the vaccines. Other than the obvious ethical reservations that people might have regarding how the serum is collected, it's shown that the use of FBS in cell culture carries disadvantages related to the presence of contaminants such as endotoxins, mycoplasma, viruses, and prion proteins. The composition of the serum can vary from lot to lot. The tetanus toxin is produced by growing Clostridium tetani in a modified Latham medium derived from bovine casein. Bovine casein is the most prominent protein in cow's milk. The diphtheria and tetanus toxins are detoxified with formaldehyde. According to the National Cancer Society, formaldehyde is a known carcinogen. And the National Cancer Institute states that formaldehyde is a colorless, strong-smelling, flammable chemical that is produced industrially and used in building materials, such as particle board, plywood, and other pressed wood products. In addition, it's commonly used as a fungicide, germicide, and disinfectant, and as a preservative in mortuaries. As a reminder, formaldehyde is a crucial tool for funeral directors and embalmers. It's the primary and most effective preservative used in the majority of embalming fluids on the market today. The acellular pertussis antigens are isolated from Bordetella pertussis culture grown in modified Steiner-Schulte liquid medium. The modified Steiner-Schulte medium includes ingredients like MSG. This is a preservative used in processed foods and a common flavor enhancer in Asian cuisine. Potassium dihydrogen phosphate, which is a fungicide used to treat things like powdery mildew on fruit trees and plants. The pertussis toxin is also detoxified using formaldehyde and glutaraldehyde. Glutaraldehyde is an acutely toxic corrosive and a health and environmental hazard. It's used in the treatment of wastewater, oil and gas recovery operations and pipelines, embalming fluid, and the fogging and cleaning of poultry houses, among other applications. It's also found in paint, household disinfectants, and laundry detergents. All three antigens are individually absorbed on aluminum hydroxide, and aluminum is also used as an adjuvant. An adjuvant is an ingredient added to the vaccine to enhance the immune response. Aluminum is an adjuvant that is included in several childhood and adult vaccines on the CDC immunization schedule. Each 0.5 milliliter dose of Infanrix contains 500 micrograms of aluminum. This is over 90 times the safe amount of aluminum that should enter the bloodstream of an infant that weighs 11.7 pounds. According to Physicians for Informed Consent and the Agency for Toxic Substances and Disease, which is a division of the U.S. Department of Health and Human Services. We've discussed aluminum before when we examined the hepatitis B vaccine, Infanrix B. However, let's revisit the toxicity of aluminum and the concerns that surround it. Aluminum is a heavy metal that is a proven neurotoxin and can cross the blood-brain barrier and has scientifically been shown to cause autism, asthma, autoimmune diseases, and other horrendous neurological diseases and chronic illnesses. The Agency for Toxic Substances and Disease states the most sensitive target of aluminum toxicity is the nervous system. Impaired performance on neurobehavioral tests of motor function, sensory function, and cognitive function has been observed in animals. Neurobehavioral alterations have been observed following exposure of adult or weanling animals and in animals exposed during gestation and/or lactation. The agency also states children who are exposed to high levels of aluminum exhibit symptoms similar to those seen in adults, including neurological effects and skeletal effects. And we do not know if children are more susceptible than adults to aluminum toxicity. It also contains polysorbate 80, which is used in products such as cosmetics, air fresheners, cooling fluids, flame retardants, and hydraulic fluids. I want to touch on a couple more things that I feel are really important for every parent to know about the Infanrix vaccine. The diphtheria and tetanus toxoid vaccines are credited with preventing millions of deaths in the U.S. from the time they were initially introduced in the mid to late 1940s. However, upon examining the science and evidence, a much different story emerges. If you look at this chart from the CDC, it only goes back to 1920, but you can clearly see that the reports of diphtheria were rapidly decreasing since the early 1920s. The second chart from Physicians for Informed Consent shows that diphtheria mortality was at a sharp decline since 1900. By the time the DTap vaccine became widespread in America, the diphtheria death rate had already dropped by 97% from 1900 to 1945. In the U.S. right now, the annual risk of a child who is under 10 years old contracting a fatal diphtheria infection is about 1 in 1.7 million, or 0.00006%. If we look at tetanus, we see a similar story. The risk of a child under 10 years old in the U.S. dying of tetanus infection is about 1 in 784,000, or 0.0001%. When we look at the CDC graph for tetanus, it looks like fatalities start to go down in the late 1940s. But if you look a little closer, you can see that tetanus deaths actually declined by 79% between 1900 and 1945. This was still a few years before the vaccine became widespread in the U.S. Once again, when we look at pertussis or whooping cough, it looks like the cases started going down in the early 1930s, according to the CDC graph. However, when we examine the graph from Physicians for Informed Consent, we can see that, aside from the spike around 1906 and 1918, deaths from whooping cough have been in decline since 1900. In fact, the mortality rate declined by 92% from 1900 to 1945. The pertussis vaccine was not widespread until the late 1940s. Today, a child in the U.S. under 10 years old has a 1 in 46,000 chance of contracting a fatal pertussis infection. That's 0.002%. Many people attribute this drop in diphtheria, tetanus, and pertussis deaths to better sanitation practices, better nutrition, access to clean water, and access to appropriate medical care if they have complications with these infections. Diphtheria can be treated with diphtheria antitoxin and antibiotics, erythromycin or penicillin. Respiratory support can also be used if needed. If a person is exposed to tetanus, the infection can be treated with immune globulin, wound care, antibiotics, and environmental support. Respiratory support can also be available if needed. Whooping cough is mainly treated with rest, hydration, and antibiotics if needed. The vaccine does not prevent transmission or asymptomatic infection for diphtheria or pertussis, and tetanus is not a contagious infection, so it cannot be transmitted. The DTap vaccine, Infanrix, is often combined with the inactivated poliovirus vaccine, which is a vaccine known as Infanrix IPV. There's also a vaccine called Infanrix Hexa. This is a combination vaccine with 10 antigens, which include the Infanrix DTap vaccine, the hepatitis B vaccine, the inactivated poliovirus vaccine, and the Hib vaccine. We will discuss these vaccines in a separate episode, but please be sure to conduct your own research on every vaccine, especially combination vaccines. They are not safe. CHD senior scientist Carl Jablanowski and CHD's chief scientific officer, Brian Hooker, wrote a paper called "The Adverse Outcomes Are Increased with Exposure to Added Combinations of Infant Vaccines." This paper shows that each additional vaccine in the combination more than doubles the developmental, respiratory, or suspected infectious diseases diagnosed. So in short, the more vaccines that are in the combination of a vaccine that a child receives yields an exponentially greater number of disease diagnoses. I know this is a lot to take in, but I hope this information will help guide you in your research and assist you in making the right decisions for you and your family. Thank you for watching, and I hope you have a blessed week. We'll see you next time on Vaccine of the Week.